whole story has been sort of really on the back burner, but it's still the elephant in the room, if you like, going on in the background. If you want to know what percentage of what percentage you can get away with of debt as a relation to GDP, I think probably Ireland and Iceland give you an idea of when things start going pear-shaped. So that just tells you where we are in terms of financial crisis. And so that takes us to looking at where UK government spending is, how it's allocated. So for 2011, a quarter of the budget will go on healthcare. The UK NHS, National Health Service budget, so for 2010-11 is just over $170 billion. That's dollars US, so we're about the same in Canadian, not quite a week. Just tell you about the National Health Service. Different, I think, from a lot of countries. 92% of all healthcare service is public sector, comes from government. So if I or my family are ill, we go straight to hospital, we don't pay anything, it's all done. I know there's certainly at least one person in this room who's found himself unwell in London and had to have all sorts of scans and treatment and so on, no charge. How does that work? There is a private sector, but it's insurance driven, but it's a very small percentage. So the NHS, it's a monster. It employs more people than the Indian Railways, and just a fewer than Walmart and the Chinese army. So that's a lot of people. And if you look at the relative populations, that does tell you there's something a little bit wrong there. But anyway, it's a big employer and there's a lot of waste. And it's a supertanker, frankly, and to actually, as we know, a supertanker is very hard to stop, takes a long time to turn them. And the current government, we've just had a change of government, and that's what they want to do. They want to try and address inefficiency while protecting service. So very, very tough call. So how are they going to do that? This is how it's been working for the last 10, 20, 30, 40 years, is basically the budget is held by the Department of Health. They then have underneath them some primary care trusts who are basically run by administrators, and their job is to feed that finance through to the hospitals, the doctors and the dentists, who in turn treat the patients. So, as you say, if I'm ill and I go to hospital, I don't see anything to do with this finance flow. But they've been working with this system for quite a long time, so it's a top-down planning process. Each hospital has a fair idea of what the demand looks like. They've got the age profiles of the population. So it's a relatively well-trodden path now. Not run efficiently, but that's another story. But what do they want to do in the future? The Department of Health will still hold the budget. But now they're going to set up a new body called the NHS Commissioning Board, who will distribute the budget, and they'll get rid of most administrators. One of the targets is to cut administration costs by 50%, and in the NHS, administration costs are very high. And then they're going to give the money to the doctors. So the doctors are being asked to produce or create consortia, groups of doctors, and they will own the budgets. And the thinking is, of course, they're much closer to the patients. They should be able to buy the healthcare that they sit between the patient and the healthcare providers, if you like. So they should be able to do the matching much more efficiently and run it much better. So the doctors then will be feeding funds and buying services off the different providers. Now, if you're a hospital, then that landscape has changed dramatically. This doctor may have been buying services or been sending his patients to you because he was told to. He's now going to say, no, actually, there's a hospital 20 miles down the road, much better at a particular area, pediatrics or whatever. I'm going to send my patients to you instead. So demand planning becomes a real nightmare, and then, of course, that feeds through into what resources you need. So on top of that, treatment costs are going up in price, and also the population's aging. So we've got the insidious forces of inflation pushing on things. So the budgeting challenge is the traditional ones, which is basically how do we balance our finances. They're also being asked to cut their costs, so there's pressure from that side. there's all the government and healthcare reform going on, and then there's inflation as well. So the picture is becoming much more complicated, and all the way along, they have to make sure that patients are being properly cared for and looked after. So not inconsiderable as a challenge. Just one aside, I wonder how many of you, if you do budgeting and planning, at the end of your process, turn around at the end and say, right, what did that cost us, and what was the benefit we got? How do we quantify that? I don't think really when you're going through a budgeting process, everyone takes it as a given almost, that of course you've got to budget, and of course there's a value. But is it quantified? And the fact is, if it's not quantified, how can you know if you've overspent on your budgeting process or underspent? How are you measuring its efficiency? And if you look at it very simple, in simple terms, in this example, the budget is the size of the cup, and that might be larger one year or smaller and another. And you've got a finite number of resources that you're trying to control or squeeze into that cup. You will always build in a margin of error in your budget as well. And if you're running your processes efficiently, you're trying to obviously maximize your use of the budget. You're trying to control as much as you can the resources that are going to be applied elsewhere, but also manage your margin of error. It was interesting in previous presentations. I think Mike was talking about Talisman and its budget overruns. I mean, budget is overrun. They're also underrun too, and you see people spending furiously in March at the end of the financial year, that sort of thing. So it is the more accurate you can make your budgets, the better it is going to be for your organisation. So how has one hospital dealt with this? It's Royal Berkshire, who started using Palo just over 18 months ago. Just to give you some background about them, they are just west of London, based in Reading, in fact, and they cover an area just west of, quite a large one. In fact, they're one of the largest hospitals in the UK. London obviously has lots of hospitals, but Reading, for some reason, is a very, very big area to cover. Just to give you some stats, just under 5,000 staff, an annual budget of nearly 470 million, 16 babies born a day, lots of meals. Typical, probably sort of small-sized hospital in Canada and the US, but for us that's big. And they're very good. They're run very efficiently. Ticking all the boxes in terms of quality. How they organise, there's a trust board, a chief executive, all the clinical work is managed under the clinical directors. There's estates and facilities, and then there's an executive team managing all the finance, admin, and so on. And the budgeting and planning team sits in finance, supplies, that area. And they have, in the whole organisation, about 150 budget holders. So quite a lot of people to deal with. So their challenge is, first of all, how do they estimate demand out to 2013? That data in the Palo model actually comes from somewhere else. So there's another team doing that. But once they've got those figures, and they'll be changing all the time, the issue for the planning team is really how many staff they need, and of what type, what grades. Part-time, there's a lot of contractors involved in hospital work, so managing that demand and supply balance. What are the financial constraints? So how can we plan within those constraints? But most important of all, how do we communicate that? How do we work with all those budget holders to agree a final budget and get a number that's reliable? So before Palo, they had an Microsoft Access-based relational planning tool called Beams. In their words, really laborious, very, very time-consuming to deal with. Very high training and maintenance costs. It's a very specialized tool. Not at all flexible, very difficult to change, and very non-scalable either. You couldn't really model in it. It was, you put results in and you got an answer. Lots of guesswork, and basically inaccurate. And inaccuracy breeds mistrust and lack of confidence, and that really went all the way up to the board. But for the lack of anything better else, that's what they had to use. They had also monthly reporting packs, which they did actual versus budget reporting, which involved manual work. very high dependency on IT resources, which was a problem not only for IT but also for the financial planning team as well. So if one of the financial planners wanted to look into that data model of where all their data was, this is the sort of picture they'd be looking at, and not something that a finance person would normally have the skills to manage, change, adapt. A good IT person would understand that and be able to change it under instruction, but they wouldn't know necessarily why it was being changed and what the ultimate planning objective was. So not a helpful view of where their data is. So when they were looking for tools to use, the selection criteria they went through was, first of all, they wanted to use Excel because everything eventually ended up in Excel. So if they could keep doing that, that's what they wanted to do. They wanted something that's very easy to use, to develop, customize, fast, flexible, all the buzzwords, all the requirements that everybody's got. They don't want to be wasting time doing this. They wanted to be doing top-down as well as bottom-up planning. They wanted a clear audit trail, reduce the guesswork, and therefore increase the credibility of the numbers coming out and increase the accuracy. They wanted to automate the reporting. They wanted the planners, the people in the finance team, to be able to really manage the process and not dissipate it across the organisation. And really reduce their call on the IT resources, which are very valuable IT resources, specialist skills, which really shouldn't be dragged into this area. So at the end of the day, return on investment is accuracy, credibility, process improvement, all the things we've been hearing about this afternoon. So when they looked at the market, there are sort of two categories of tools out there, the relational ones and the cube-based ones. Having been down the relational path, they took that one out of the equation. But even in the cube-based tools, there are tools that are more appropriate than others. So they removed all those that didn't have the ability to write back the data to the database. And Matthias has shown us earlier how well that works, and you've seen that in other presentations. Once they'd narrowed it down, they then looked at the planning functions, what the final selection criteria, what the planning functions are in the software, how easy is it to use, how quickly